I did not receive any honorarium to chat about the CAR T today, and we will be talking about CAR T cell therapy made by two companies with Janssen and Celgene. And for the purpose of CAR T, I have not received any honorarium from them, but I have participated in advisory boards and speaking engagement for other types of therapy. So our objectives today is really to understand what CAR T, chimeric antigen receptor T cell therapy is, reviewing some of the data that are available on CAR T cell therapy in myeloma, and discussing the implication of CAR T cell therapy from the patient perspective. Can you still see?
Mm-hmm.
Okay, great. So we can't really talk about CAR T cell therapy without chatting about the normal immune function. And in our normal day-to-day life in our body, we have two different immunity. Innate immunity, which is something that is used in the body to continuously patrol for any foreign substances, infections, pathogens in terms of, and it is the system that the body can use to rapidly respond to infections. And you can see in this graph, the picture here, there are multiple cells that are involved in the innate immunity. The ones we talk about most with patients tend to be neutrophils, the white blood cells that are important in fighting bacteria, eosinophils, ones that are important for dealing with allergens. But ones that we would want to chat about today a little bit is the macrophage and dendritic cells. Those actually we don't talk about a lot, but they are responsible for eating up pathogens and then presenting specific markers of the pathogens onto their cell surface. And they travel to the lymph node to trigger the adaptive immune system. And our adaptive immune system is a bit smarter and specific in killing the pathogen or foreign substance that the body is dealing with. So we have our lymphocytes there. And with lymphocytes, which are white blood cells that fight viruses, you have your B cells that initially makes just generic antibodies, but then creates more targeted antibody with exposure of the antigen. And T cells, which is important, they attach themselves to foreign antigens and kill the foreign substance, and can also trigger the immune system to destroy by recruiting other types of immune cells. So this is a schematic, a picture that can illustrate what the T cell that we're most interested in talking about today, with cytotoxic T cells that normally the body has. So this is the one down here. And in terms of, this is what you might see with a foreign substance, foreign antigens on the surface of the cell. And what happens in the normal environment is that the T cells will attach itself to this antigen with a receptor, and then releases chemicals that actually punches holes in the surface of this infected cell, okay? And then by punching holes in the cell, what happens is the cell gets destroyed and die. So that's really the powerhouse of our immune system in killing abnormal cells and infected cells, infections most commonly, and what our body recognizes not to be self. And cancer is actually quite smart, and how it interacts with the immune system is quite unique. And B cells can still release antibody and recognize the cancer cells to kill the cancer cells. But what is important to know is that the killing power is not so good. It's weaker, much weaker than the T cells. But the T cells sometimes can be, in terms of fooled, and cancer cells have tricks and tactics that can escape the T cells from actually recognizing it. This is where chimeric antigen receptor T cell therapy is particularly important. So what does chimeric antigen receptor T cell, CAR T cell, mean? So the chimeric antigen receptor means that it is two special features. It has a monoclonal antibody component and a T cell receptor component. And in terms of it is important in helping our immune T cells recognize the cancer cell and kill and attack the cancer cells. How is that done? So in terms of there are technology that is able to genetically modify T cells by using a virus, infecting it with lentivirus. That has a gene that encodes for the T cell to express receptors, okay? And these receptors would recognize the cancer cells by having a target in the receptor and in terms of killing the cancer cells that way. So CAR T cell therapy, when we talk about it, there's a few major components of it. We talk about, like I said earlier, there's a gene with the viral vector that actually encodes for the T cells to make these receptors. And in terms of with that, the receptors here has a couple components. There's a binding component that binds to the cancer cells. There is what we call a co-stimulatory receptor signaling domain that actually helps with the T cell population expanding and actually lasting in the system. So helps with multiplying the T cells, recruiting more immune cells, and also keeping it in the system so it has a longer lasting effect, which particularly is important for disease that are known to be less but not curable because they tend to escape the immune system. And in terms of the third component is the activation component that actually tells the T cell release those chemicals to kill the cancer cells. So what happens with CAR T cell therapy is that the T cells are collected from patients. And then in terms of a similar process, we call that leukapheresis. This is a very similar process to when we collect stem cells, okay? And then it is shipped to manufacturing company to genetically modify the T cells. What happens is oftentimes the company will select for the T cells that are of interest, that the cytotoxic T cells, and then in terms of genetically modify it, and then multiply it in numbers, and then re-infuse it back into the patient's body to help with killing the cancer cells. When talking about how it has a role in multiple myeloma, it is important for us to really talk about the different classes of drug in multiple myeloma. We have multiple classes. The commonly used ones are what we consider chemotherapy, particularly the most common the ones we talk about is cyclophosphamide and melphalan that are used. Corticosteroid is another class. Dexamethasone, prednisone are ones that we use in myeloma patients. Proteasome inhibitor, which is bortezomib or Velcade, or ixazomib or carfilzomib that you might be getting as a myeloma patient. Immunomodulator, which is lenalidomide or Revlimid, or pomalidomide or Pomalyst. And targeted therapy is the newer of the treatment. Previously, most of the other treatment is not so specific to just plasma cell itself. And the targeted therapy tend to really target the markers that are on plasma cells, specifically on plasma cells. One of the common one we talk about is CD38, cell differentiation 38, that are in plasma cells and some lymphocytes. And the newest one, one of interest of many of the study drugs is BCMA, which is B cell maturation antigen. This is quite exclusively present in the mature B cells and plasma cells in the body. I'll just mention the anti-CD38 antibodies that are normally used now is daratumumab or isatuximab for those with private insurance, and it's standard of care now for myeloma treatment, usually in first or second line. This is the funding algorithm for Canada that has been recently revised, and the ones in the white is publicly funded in all provinces. The one in the gray is not publicly funded, but in terms of in the province, and the one in the blue is the newest addition that we have. But as you can see, myeloma treatment can be quite complex, but the main takeaway point from this side is very much that when we look at treatment for myeloma, we generally look to use 3 classes of drug at a time. And in later lines, sometimes it might be 2 classes of drugs, but that is less commonly used. And the patient journey for myeloma can be quite different based on the timing of approval of drugs and funding. What is important here is, that I wanted to mention is there is certainly an unmet need in multiply relapse or multiple myeloma. This is actually, I want to mention a study that was prospective that follow patients with myeloma and the ones who have been relapsed or refractory type of myeloma in Europe and in the United States. And they looked at actually what happened to patients who have been exposed to the 3 classes of drug with proteasome inhibitor, an IMiD, immunomodulator, and an anti-CD38 antibody, and what happens when they relapse. And what they are seeing is this is a progression-free survival chart that with the next line of treatment, what they see, we never talk about the best, we never talk about the worst, we talk about the middle person. The median person in terms of for progression on the next line of treatment is only about 4.5 months. And survival, which is the graph here on the B graph, and the middle person lives around 12 months. It is important to know that when we look at these graphs, you can never predict a patient in front of you. It can just tell you what happens to the middle person. And what is a little bit more reassuring is here, and the following graph is looking at if for the next line of treatment, what happens if they got a very good partial response or better, so where we can kill off more than 90% of their myeloma. The green line is where it shows that those patients do significantly better than the patients who were not able to achieve that in terms of type of response. So this is where data for T-cell therapy has been important because we know that the prognosis for patients who have had these refractory or exposed to these 3 classes of drugs, they don't do as well. And so there are studies with CAR T-cell therapy with the 2 trials we'll talk about with KarMMa trial and CARTITUDE trial. So particularly in myeloma, in terms of we talked about the CAR T construct a little bit, and in myeloma, it is directed to BCMA, the B cell maturation antigen. And currently, the 2 approved ones in the States and in Canada, one of them is approved, is either captogene Lenluso or ide-cel is the actual short form for that, which most people use, as you might know why when you hear me talk about the name. And captogene autoleucel is the other one, the newer one. Cell is the other name. The main differences, they are quite similar in construct. Main differences is that ida cell actually only binds to one epitope of BCMA, whereas the CETA cells binds to two. There's two binding sites. So the postulation with the two binding site is it might have a higher affinity to myeloma cells, might have a higher effect. It has never been compared side by side, so we don't know in terms of for sure. There are a little bit of subtle differences with side effect and whatnot too, which we'll talk about. So what is more important is what is the efficacy of these CAR T cells? Well, the first trial that was published in New England Journal of Medicine in a year and a half, 2 years ago now, with the ida cell, idacaptogene benzoyl. And with the study was a single arm, that this is an important point to highlight. There was no comparator in this trial. They only looked at patients with myeloma and who has had 3 or more prior lines of therapy, and like I said, had to been exposed to IMiD, immunomodulator, proteasome inhibitor, and an anti-CD38 antibody, and has been refractory, has not responded to or progressed on the last treatment. And what they did is they took those patients and they have to have good, in this trial, good organ function. Bone marrow reserve has to be good with a good count where they're not needing transfusion. They have to have good kidney function in this trial. And what they did was they took their leukapheresis, took their T cells, manufactured the CAR T cells, and once they realized the patients have got the CAR T cells manufactured, they depleted the patient's lymphocyte in the body with chemotherapy, and in terms of with cyclophosphamide and fludarabine. So this regimen is the best known regimen and is used across the board for all CAR T cell trial now because it is very good at killing B and T cells and allowing for the CAR T to expand once it is infused. So this is always done prior to the CAR T being infused. And in this trial, it looked at 3 different dosing in terms of the number of CAR T cell that is infused. And it is important to know that at the end of the trial, they picked the highest dose, and we'll talk about implication of how it affected the data. And what they looked at was how many people responded of the people who got it, how many people got complete response, basically undetectable myeloma, and what the safety was like, duration of response, overall survival, and quality of life. And when you look at the actual characteristic of this trial, the patients in this trial, they were a third of patients at high risk cytogenetics. Those are patients that normally we do tandem transplants, 2 transplants back to back. They also had a high number, almost 40% of people with extramedullary disease, which means that the myeloma is quite advanced, where it's not just in the bone marrow, it's outside of the bone marrow in terms of in their disease. And the patients have had a median, not the most, not the least. The middle person have about 6 treatments prior to getting CAR T, so heavily pretreated. Some even got up to 16. It must be a really patient who have been diagnosed long ago where they use singlet, like 1 class of drug at a time. And triple class refractory in over 80%. And what they saw was that of the patients, 73% of patients responded and had improvement in the myeloma. And you can see the schematic here, what that looks like. And in terms of patients, 33% had complete response or stringent complete response, where they're not able to detect the myeloma protein at all, the blood, and some in the bone marrow even. And in terms of another 20% had at least 90% reduction in the myeloma protein, and another 20% had at least 50% of reduction in the myeloma protein. So quite impressive response rate. And the median duration of response we talk about is over 10 months here. And in terms of when you look at how many at the 2-year point, how many people are still alive, more than half of the people are still alive. And when they looked at the different dosing, they did see what is not surprising is the more CAR T cells you give the patients, the better, the more people responding, and the better, deeper response we saw with this trial. And when they looked at how long do the CAR T last in the body, up to a year, is what was seen in this trial. The next other newer CAR T we talk about is Selay with the CARTITUDE-1 trial. This is an interesting CAR T. It actually has been around quite some time. It originated from China. You might hear about the CAR T that was used in the Legend trial. In terms of in China, it was because actually anti-CD38 is extremely expensive. It's much cheaper for in China to actually make CAR T than to get antibodies for their daratumumab, isatuximab. And so CAR T was used very frequently and discovered there. And what was found is this particular CAR T is very effective against myeloma. But with the data from China, it was not as relevant to our patients because a lot of people never got the antibody against CD38. So the CARTITUDE trials, there's a number of them. The first one that was done is, again, looking at more of the patient population that is reflective of what we would see in Canada. And again, 3 or more prior lines of therapy previously. Again, they high-risk features with high-risk cytogenetics in about a quarter of patients. Quite a few, more than almost 15% with myeloma outside of the bone marrow. 6 prior lines of therapy is the median, and almost 90% of patients have had triple class refractory. And what they saw, remember I said that this was one with the 2 binding sites to the binding sites to 2 epitopes of BCMA. And they saw an overall response rate very close to almost 100%, now 97% here. And actually majority of them was a complete response. And in terms of what they saw was at the 27-month mark, less than half of the people have progressed. And in terms of overall survival was not reached there. 70% of patients at 20 or more than 2-year mark are still alive. And looking at the 2 trials, at the progression-free survival trial, you can see here the better responders, the complete response patients have a better curve where in terms of this is with ida-cel, this with Selay. You can see the patients who achieve complete response always do better than everyone else. And in terms of non-responder, you can see that curve here is quite steep. They progress quite quickly. And this is what we saw earlier of the prospective study that looked at people who have been exposed to 3 classes of drug, what happens to 4.5 months progression-free survival without CAR T cell being available. So certainly very promising in myeloma. But there is no trial that looked at what happens if someone gets CAR T versus don't get CAR T head-to-head in a phase 3 randomized controlled trial at the moment. And what has been done, though, is a comparison with a match cohort in terms of using registry data with database. And in terms of this was published late last year, looking at a match cohort from registry compared to the KARMA cohort. And these are all patients with a match cohort, are all similar, where they are fit, don't have a lot of comorbidities, and have good performance status. And you can see here when they look at the match cohort with the CAR T, certainly we are seeing that the progression-free survival looking quite good in comparison to the match cohort, and even overall survival looking quite good compared to the match cohort. But this is not considered the high-level data from the government point of view and funding body point of view, just keeping that in mind. So more importantly, I know I'm chatting with the patient support group. So what is important to the patient is, what does the patient journey look like with CAR T-cell therapy? And we have quite a bit of experience with this, because the CAR T-cell therapy is a standard of care as for aggressive lymphoma patients and in selected acute lymphocytic leukemia patients. So the most important thing is patient identification, early identification through blood work, being able to identify patients who are in biochemical progression. And spelling error here. For patients who have had at least 3 prior lines of therapy, or on their 3rd line of therapy, in terms of having been exposed to a PI, IMiD, and anti-CD38, those are ones that are closely followed in the cancer center and with surveillance blood work by the myeloma group. And when we start seeing markers like the myeloma markers starts rising, we always start talking about what is next in line for treatment, and if patient is appropriate for CAR T cell, that's what would be talked about. And the appropriateness for CAR T cell would depend on a few things in terms of the selection wise is on fitness, not just age itself. What we do look at comorbidities and whatnot. And then once the discussion occurs and patient would want to pursue that, then we get the consent form to signed and a release of information so we can proceed on with application process. And generally at that point, because in London we're not doing CAR T-cell therapy at this point, we would talk about where available sites for CAR Ts are and which patient would prefer. It is important to note that initially in the implementation of CAR T-cell approval for lymphoma and leukemia, patients were being sent to the States out of the country in terms of for this because there was just the resource and infrastructure was not available in Canada. And I suspect it might be the case in myeloma if the CAR T is approved. So when at the initial phase, what we ended up always having to do is asking patients, do they have a passport to go to the States? And those are things that not oftentimes we think about normally, but it is something that can play a factor. And then we move on to the application process for funding. And in terms of, like I said to you earlier, initial phase tend to be out of country access. So it tends to take a longer period of time to get approval because of the review process with that. And it occurs when there's not enough capacity. In some of the other provinces, they send to the States because in the East Coast, there's not a lot of center that would do CAR T. So it's actually closer to send to the States and there's more capacity. And previously for lymphoma patients, we sent to Buffalo, to Roswell Park and Mayo Clinic. And once infrastructure is in place, the in-province access is very much standardized. There's a standard form for each indication, and it's submitted through online platform. In London, we have a very streamlined process with our transplant coordinator and clerical staff that helps with that process. So it's not relied on just the doctors to do all the paperwork. And once it's submitted, it is reviewed by one of the other experts in the province and for approval. It takes about 1 to 3 weeks for approval, depending on how much back and forth extra information is needed. Then once approved, patients get their consultation with the CAR T-cell therapy sites. In Ontario, currently, Hamilton, Toronto, and Ottawa are doing CAR T. And all the sites who do CAR T have to be FACT accredited, which is an accreditation process for cellular therapy, which London is in its process of getting accreditation with reliance, which is also dependent on the actual expansion of the transplant program. And for each site, it also actually has to be certified by the pharmaceutical company. And in terms of to provide CAR T, so each product actually has their different pharmaceutical company has different specification on how shipment and handling of the collected T cells should be and handled, whether it's frozen or fresh samples, and how they get infused back and what type of monitoring and requirements are needed. So although we have 3 sites in Ontario to do CAR T, not every product of CAR T is available at each site, depending on the certification of that. So from timing from the approval funding to the consultation usually takes about 1 to 2 weeks. And then what happens is patients get arrangement if deemed eligible and suitable for CAR T is a collection date at the site where the CAR T is done with a leukapheresis that is shipped to a manufacturing company. All of the CAR T are manufactured in the States, and usually there's 1 or 2 manufacturing company in the States for each product. And it takes about 17 days to up to 4 weeks to get the product manufactured, depending on the product. And then at the once we figure out that there is the product is successfully manufactured, then patients would get the lymphodepletion with the chemotherapy, the lymphocyte, and they get it infused as an inpatient for myeloma patients and stay as an inpatient in the hospital for 7 days to 10 days, depending on the product, and then has to be living very close to the center and be assessed every day for up to 4 weeks, up to a month. And what are the side effects? We'll chat about that, but the timing-wise, you can see in terms of from time to consult to apheresis can take up to a month, depending on capacity. And from the time of collecting the T cells to the time where it's manufactured and infused, it can take up to 2 months. So in terms of, it is very common from the time we identify the patient to the time they actually get the CAR T, it takes about 3 months or so. And during that time, there's very close monitoring to ensure that patient's disease and myeloma is not going out of control. Okay. I am just seeing a couple questions in the chat. Is there an age limit for this treatment? No, there is no age limit. In the lymphoma world, I think in Ontario, the oldest patient we have sent is 84. And it's more based on function and how fit the person is, and whether there are other comorbidities that we'll talk about the side effect and why there is certain criteria for fitness. And I also see a question on killing both T and B cells. Good question on what happens to the B cells. They can actually be low for a very long time, and which is one of the side effects of CAR T. So for the CAR T, most of the patients, when we send patients for CAR T from London, stays out of town for 1 month, and then comes back and gets continued monitoring in London. So side effects. What are the side effects for CAR T cell therapy? They are broken down into the short-term acute phase side effect and the late side effects. The short-term side effect, the reason why patients have to stay in the center or very close to the center of the CAR T cell therapy center the first month is because of things like cytokine release syndrome, we'll talk about that, and neurotoxicity. And other things that they can also see during this time is low blood cells in terms of needing transfusion with platelet, hemoglobin, or red blood cells, very low white blood cells, low B cells where they can have very low antibody level with infection risk, and very rare in myeloma to see tumor lysis with kidney problems from that. In the later long-term side effect, after the 1 month point, what can be seen is people can still have, because of the chemotherapy components, low blood cells needing transfusion, low level of B cells, which make people have a low antibody level, tend to be more susceptible to pneumonia, lung infection, and sinus infection. Not infrequently, patients are needing replacement for antibodies. And then T cell deficiency, which is what the normal T cells are low. So infections is the main side effect with there. And there are residual symptoms that might be coming from the acute symptoms. Not to forget long-term effects would be in terms of secondary cancer. With more chemotherapy and treatment comes higher risk of getting another cancer. Skin cancer that is non-melanoma tends to be a common one that we see, but we also see other things. And just like when we do stem cell transplant with chemotherapy there, patients can experience fatigue, low energy level for a bit of time. So cytokine release syndrome is one that we talk about quite a bit for CAR T. This is what happens when chemicals are released from when the CAR T engages and kills the cancer cells and start recruiting other immune cells. When a lot of these cytokines or chemicals get released, it can cause different symptoms. The most common one is fever, low blood pressure, fast heart rate, or low blood oxygen level. But it can really affect anything with these cytokines that get released. It can affect the liver, it can affect the lungs, the kidneys, and people can have nausea, diarrhea, and just feeling generally weak. But the more important ones we talk about is blood pressure being low and heart rate being fast, with can have arrhythmia or neurological symptoms, also with confusion and headache. So we have a grading system talking about how severe the cytokine release syndrome is. We talk about grade 1 is usually just when patients have a fever. Grade 2 is when they need some fluid and oxygen to help. Grade 3 is usually when we talk about when they're in the intensive care unit in terms of needing monitoring because they need high level of oxygen or needing medication to support the blood pressure to keep it up. And grade 4 is when you actually need to be on a ventilator to help with breathing and whatnot and life-threatening. And what we saw with the trials, with the CAR T trials for myeloma, luckily, is that lots of patients have cytokine release syndrome in the CARTITUDE trial. The one that is a little worse with that is over 90%. But when you look at it, a majority of them are grade 1 or 2, so ones that you might need have a fever with grade 1. Grade 2, needing oxygen or some fluid. Not a lot of people actually needing to be in the intensive care unit, 3%. 1% needing to, it's life-threatening enough to need the ventilator, or in terms of 1% died. Okay. And in terms of, there are medications that I use to help with that during that process. And what happens is usually the cytokine release syndrome for CTEP cell happens with not the best, not the earliest, not the latest, within a week or so, so 1 to 12 days, whereas ida cell happens actually within the week. So as a result of what was seen in the trial, ida cell people have to be in hospital for 7 days, whereas CTEP cell has to be in hospital for 10 days before they can just do daily visits. The other specific side effect is neurotoxicity. This happens when chemicals or CAR T cells or the immune cells cause the blood-brain barrier to not to be as good at and actually crosses the blood-brain barrier to the fluid that soaks the brain and the spinal cord. And what can happen is that people can get confused, they can get tremor, or have difficulty communicating. And again, grading-wise, it can be mild in terms of we look at different neurological type of assessment that are done, looking at how orientated patients are, if they know the date, know the year, the month, the city, the hospital, and for Canada, the Prime Minister at the time, and whether they can name objects, 3 objects that we ask them about, whether they can write sentences, a standard sentence, and whether they can count backwards from 100 by 10. And in terms of mild is when you're not able to do all, but are able to do most, 7 of those 10 things. Moderate, grade 2, is when you're able to do only 3 to 6 of those things. Severe is when you're not able to do any, up to 2 of those things, or if you have seizure or issues with the pressure in terms of in the brain area and whatnot. This is an example of what we tend to see with mild in terms of neurotoxicity with CAR T, where they can write the sentence very well, and then the next day it's not really comprehensible, and then the day after some medication is given, it's fine again. And again, in terms of what are the numbers looking like with CAR T, and it looks like 20% of patients have neurotoxicity of any grade, and of those a little more significant in about 10%. And in terms of when we talk about when this happens, it happens within the first 2 weeks. Median day of onset is 8 days, and are short-lived. Recover within 2 weeks again, also here. If it's more significant with grade 3 or severe, it might take a little longer to recover. So generally, we see the better, the more effective CAR T having a little more neurotoxicity, but it is well recognized about the treatment of that. With the BCMA, there are some data reports, longer-term data that some movement, we have observed some movement disorder in a couple of patients, but very small number, so still need longer-term follow-up to really see that. Well, your next question might be, knowing about CAR T cells, how long will it be before CAR T is available in Ontario and London? Well, there's a few things that needs to happen. With any drugs, a new therapy, there's a funding process and algorithm that happens. The industry, the manufacturer of the drug, with the data they have gotten, submit to Health Canada for a notice of compliance, for approval for the drug to be used for certain indication. And then what happens is the manufacturer then proceed on for cancer drugs to submit it to CADTH, the Canadian Agency for Drugs and Technology in Health, and particularly for cancer drug, the Pan-Canadian Oncology Drug Review. And there are expert panels, and they ask for input from patients, treaters, about the recommendations for that, and to see whether or not it is approved or recommended for reimbursement. And then once it gets a recommendation for reimbursement, a positive review, there is a Pan-Canadian Pharmaceutical Alliance negotiation that happens where the government, the multiple provincial government group together to actually negotiate for pricing and of the drug. And then once a negotiation agreement is reached, then the provinces would fund the drug. And funding of CAR T, Health Canada has given the notice of compliance to IDACEL already for basically the indication of what was seen in the trials, at least 3 lines of therapy, including an IMiD, PI, and anti-CD38, and having to be refractory to the last line of therapy, and that was last summer. But the CADTH, when it went through CADTH, it actually was recommended it not be reimbursed by public drug plans. Treatment of the IDACEL is actually just over $500,000 for one course of drug. And this is an example of what the reimbursement recommendation look like. Certainly that the data that is presented or submitted did show improvement in response rate with heavily treated myeloma patient, but they didn't feel that their duration of response, overall survival, progression-free survival conclusions can be drawn. Main reason for that is because there was no randomized control arm where CAR T versus no CAR T, but they did recognize that it isn't there's a met need in that area. Whereas for cell, it is just going through the CADTH in terms of submission, and they have submitted to Health Canada also. Currently, actually, with CADTH for this particular CAR T, it's open to physician and patient input up until later on this month for October 17th. Myself, as a member of the Drug Advisory Committee for the government for the Ontario, we always provide input on these on all new therapy, whether we recommend it or not, and certainly there's an unmet need. So future directions for this, there is trial underway with KarMMa-3 that actually compares standard of care to IDACEL in relapse refractory myeloma. So I suspect this is the trial that will be the one that will really help with getting the funding for CAR T cell therapy for myeloma patients. In CARTITUDE with the cilta-cel, there is also earlier lines of treatment, not just 3 lines, more reflective on real life now that the antibodies, the monoclonal antibody tends to be used earlier. A lot of patients can be triple class refractory after 2 lines of therapy. So in terms of there is a trial looking at that in terms of in that setting, comparing standard of care with chemotherapy or other therapy to CIDF cells. Other types of things that have been looked at is actually how to improve the efficacy of CAR T cell. We know that it's not a cure for myeloma, and is there a way that it can get a deeper response? And there are looks at actually adding something called gamma secretase inhibitor that actually causes myeloma cells to express more BCMA, and by having more BCMA on the surface of the myeloma cells, CAR Ts cells are more effective. And like I said to you guys earlier, the CAR T process can take 3 months. Some patients with myeloma can be quite aggressive and don't have 3 months in terms of to wait for a treatment to be manufactured. There are off-the-shelf kind of option that actually called bispecific T-cell engager, where in terms of there are antibody that actually attaches to myeloma cells with usually BCMA, and also attaches to T cells through CD3. And just by proximity, the T cells and myeloma cells already engage, it activates and kills the myeloma cells. Not quite as effective as CAR T, but it is something that is showing very good promise because actually it's off the shelf, doesn't require as much of a wait time in terms of in getting the treatment. Just in summary, the chimeric antigen receptor T-cell therapy is a very promising cancer therapy. There is emerging data to show efficacy of CAR T in myeloma patients. Short-term side effects include cytokine release syndrome and neurotoxicity that requires close monitoring in the first month, and long-term side effects include infection, requires supportive management for low antibody level, low blood count, and surveillance for secondary cancer. Right now, it is not funded in Canada as a treatment. And that's all I have, really. Any questions? This is, as you know, my daughters are 4 and 6. A show called Storybox. There's a very good episode on the immune system, and this is the T cell in the show schematic. And that's all I have. And I do want to open up the floor to questions. I see Tracy asks, where is CARTITUDE-4 being done? Right now, it is not being done in any of the center in Ontario. There are a few other CARTITUDE trials that are being done in Ontario in different settings. CARTITUDE-5 is being done in Hamilton, but that is actually looking at using CAR T cell in the frontline setting. The trials, I know Princess Margaret was looking to open one of the CARTITUDE trials also, but in the relapse refractory 3 prior lines ones, we have not had any options really right now in Ontario, even through the clinical trial right now. But things definitely change with time. And certainly whenever we see a patient in clinic, we're looking to see with the most updated trials available all the time to see what can and cannot be done. Great. So in terms of, I see another question, whether I can explain what exactly is meant by 3 prior lines of treatment. That's a great question. I'll go through that. And yeah. So if someone has had tandem transplant, maintenance with Velcade and lenalidomide, that is actually only considered 1 line of treatment. 1 line of treatment with that. So in terms of when you say triple class refractory, so if Tracy, in your place, you're on both a PI and IMiD, if you were to progress, you would be considered double class refractory, where you are refractory to a proteasome inhibitor and an IMiD. And in terms of the next line of treatment will likely include an antibody to CD38 because of all these in terms of requirement for funding and whatnot. And a lot of trials for relapse refractory setting require a triple class refractory patient. So you would go on to another treatment with daratumumab or isatuximab, and it will depend on cytogenetics, what we kind of pick with that. And if you progress on that or relapse after you get a good response, then you're considered 2 prior lines with triple class refractory. So this is what I was mentioning with the CARTITUDE-4 is much more relevant in the newer patients where you can easily be triple class refractory after 2 lines of therapy, especially with recent funding announcement that daratumumab is used front line for non-transplant eligible myeloma. And I see another question. Does triple class refractory means 3 previous lines of treatment? Not necessarily. You can, like I mentioned, you can have 3 lines, be triple class refractory without actually having 3 lines. In terms of you can yeah. So I'm just thinking for other cases, an example would be getting Cyborg with Velcade already and a transplant and then a lenalidomide maintenance. And when you progress on that, then that's 1 line of therapy. When you progress on that, then in terms of your refractory to IMiD, immunomodulator, but you're not refractory to a proteasome inhibitor yet. So generally what you would go on would be daratumumab with bortezomib or carfilzomib. So a PI with an anti-CD38 with a steroid. And then if you are refractory to that or progress on that, then that's 2 lines of therapy, triple class refractory. And then, but by definition of these trials, you need 1 more line still. And we would have to give you another line, whether it be carfilzomib or pomalidomide, before you are eligible for CAR T-cell therapy at the current data that is available. But there are more data that are coming and underway where study is being done to actually have it as a different indication where 2 prior lines only would be eligible for CAR T, or even in the frontline setting. So in terms of the government and funding body really looks at how the trial were conducted and what the indication or the criteria for the patient recruited is, and follow that exactly to a T. And in myeloma world, it can be difficult because things change so fast, and even 2 years can make a huge difference on what options we pick for treatment and whatnot. So to really reflect the landscape of myeloma patients and what we see in clinic really requires a lot of ongoing clinical trial to get that data and the funding approval. Any other questions at all? I hope that was informative and clear in terms of what CAR T-cell is about.
I'm just wondering, Dr. Lam, I have a little tag on my question. Is it, so CAR T-cell, is that if nothing else is working and you're in a desperate situation?
Yes and no. Right now, the most data is on the 3 prior lines and also triple class refractory. So in terms of in that situation where the prognosis is really bad, it is considered a desperate situation. And we have sent people to the States for them, whether it be private insurance funded or in terms of self-funded for those indications, as trial has not been readily available. And in terms of with the current trials that are looking at CAR T, is looking to move it towards the front, closer to just less pre-treated patients, thinking that there would be better effects when the myeloma is not as aggressive. I think most of the myeloma treater would mention that every time the myeloma progresses and relapse, it tends to be more aggressive, it tends to be smarter, and tends to be able to escape the immune system a lot better. So if you have an effective treatment, you want to try to use it earlier rather than when you're out of desperation and when the myeloma has really gotten under control. So this is why we see daratumumab and anti-CD38 now in the front line. And we also are seeing a lot of trials of CAR T in second, third line instead of fourth line or later. Okay. And I see another question from Andrea. If you fail on one type of immunomodulator drug, are you likely to respond to a different immunomodulator drug, or would you change to a proteasome inhibitor? So that's a great question. In terms of lenalidomide, is something everyone really see within their first line of treatment right now as an immunomodulator. And most people, when they relapse, are refractory to IMiD. And pomalidomide has been studied in that setting and has been shown to be effective in that setting. The duration of response, though, really has a huge variation that we are seeing in myeloma patients. Generally, what we would do in those settings, we would try to, like I said earlier, the multiple classes of drugs, the more the better, to be honest. So we always try to use 3 different classes of drug at the same time, and try to use drugs that based on funding criteria. There are multiple different restrictions we have, that we have to use certain drugs early. And so we keep those in mind. And also the side effect profile, we keep those in mind to see which one is the best choice for the patient in that perspective. Some of the drugs also require a good immune system to work, like the anti-CD38 antibody. So we try to use it earlier rather than late. So with those principles, we individualize patients. And I am just seeing another question. If there is insurance available, do you recommend targeted therapy as the standard of care? In terms of if if insurance is available, I would still recommend, an anti-CD38 antibody. Right now, we are able to couple it with patients with insurance to better proteasome inhibitor, or couple it with, in terms of better IMiDs and whatnot. I would still use those before I go for CAR T cell therapy. I do want to see a longer term data on the toxicity profile. To be honest, I think for CAR T cell therapy, when you look at the trial, most of the patients, over 95% of the patients, have had autologous stem cell transplant before. So in terms of with myeloma, because the age limit is, loosely at 75, but we do 76, 77 every now and then if they're very fit. So in terms of with CAR T, you basically are looking at a pretty similar type of patient population. It's rare to see patients who are in the 80s that would be very fit to get the chemotherapy component. Generally get the benefit of seeing how patients did with their actual stem cell transplant to really predict side effect wise from the chemotherapy component of CAR T, whether that will be very much affecting patients' quality of life. So if I have someone who went through a stem cell transplant and took a year and a half to really recover quality of life wise, I would let them know, you know, with CAR T cell therapy, there is a chemotherapy component that to deplete the lymphocyte. And as a result, you would have similar side effect with the fatigue, sometimes the nausea and whatnot, and the infection side effects. So in terms of, it's certainly individual case by case kind of discussion is needed at that point to see, would you prefer doing that, or would you prefer doing a continuous therapy of a certain other options that is more targeted therapy without using the CAR T. Great. Any other questions?
Okay. I'm gathering, Dr. Lam, I think we've exhausted quite a few questions there. That was an incredible presentation. Thank you so much. I know I learned lots. I've got lots of notes written down, and I'll probably watch the recorded version again, because there's just so many aspects to kind of wrap your head around. But thank you so much. You've certainly shed a new light on it for myself, and I'm sure for everyone else who's here. So, oh, and I just see one more question popped up.
Yeah, I see Tracy asks, CD38 requires a good immune system. How does anyone have a good immune system if on lenalidomide? Luckily, the trials that looked at anti-CD38, a lot of patients have been exposed to lenalidomide already, but we do know that patients who have had less prior lines of therapy has a better effects from in terms of an anti-CD38 antibody. And this is part of the reason why whenever we see a patient with myeloma, we try to use it as early as possible. Your immune system is much better the earlier on in your disease than later. So we try to use it in the first and second line in terms of with that. So that's a great question.
Okay. Well, thank you again, Dr. Lam. We're very pleased that you could join us. We know it was a little delayed due to COVID, having you meet with our group, but we really appreciate it. And again, very informative, and thank you. We really appreciate your time today.
You're welcome anytime.